my colleagues, Dr. Koshkin and Dr. Jindal, previously presented data at ASCO GU and at ASCO in 2023 about somatic alterations associated with overall survival with enfortumab vedotin. So the generation of this project really came out of my interest in treatment-related toxicity. And initially, I wanted to examine germline mutations associated with toxicity, as there is some data in breast cancer with taxane-related neuropathy associated with certain germline SNPs. However, we didn't have enough of that data available in the UNITE registry as a retrospective registry. So we decided to examine somatic mutations using multivariate analyses controlling for pertinent clinical factors. So what we started with, we had 607 patients at 16 US sites. 375 of those patients had EV treatment-related adverse events. And then we narrowed it down further to those who had available NGS data. So that was either liquid or tissue somatic NGS, and that narrowed the population down to 275 patients. Most common side effects we saw were neuropathy, which is about 46% of patients, skin toxicity, fatigue, GI toxicity, cytopenias, and anorexia or weight loss. And that was in descending order of frequency. And the median time from EV start to AE onset was about 4 weeks, with a range of about 2 to 11 weeks. So for the previous iterations that examined outcomes between survival and somatic alterations, obviously we had much larger data sets. This was a much more focused data set, given that patients needed to have EV treatment-related adverse events and available NGS data. So really, enfortumab vedotin is a very powerful, potent drug with fantastic response rates, as we saw from the ESMO data from EV302. Now, anyone who treats metastatic bladder cancer will tell you that often the dose-limiting toxicity or biggest reason for patients stopping treatment is due to development of neuropathy. Other times it can be skin toxicity, but I would say the most common will be neuropathy. Other patients I've also seen due to fatigue and anorexia, weight loss as well. So what is the goal of studying toxicity and trying to identify predictive biomarkers of toxicity is that we know from breast cancer, and at least for taxane-related neuropathy, there are differences in patient characteristics, and that some patients may have a lower threshold to develop toxicity. So if we can identify almost personalized toxicity management and identifying these patients earlier, then we can adjust doses or dose schedules appropriately so that patients are able to stay on drug and deem to benefit from this. So germline makes sense, obviously, because those are kind of things inherent to us that could affect pharmacodynamics or pharmacokinetics. However, somatic alterations can certainly influence the tumor microenvironment. And so it was a reasonable question to ask to see if any of those alterations are associated with any difference in, either PK or PD of enfortumab vedotin. So we examined probably a litany of clinical variables, and then also about 16 kind of groupings of somatic alterations that were the most frequently occurring in patients. So these were genomic alterations that were present in over 5% of patients. And there was about 16. We grouped DNA damage response repair alterations into one group. And then we also grouped CDKN2A, CDKN2B, and MTAP alterations in another group as they're located on the same chromosome. Other alterations were individual alterations. So we looked at common clinical variables just to get that data, and then those specific somatic alterations that we were talking about. So first, what we did was we looked at univariate analyses of all of those clinical variables and all of those somatic alterations with their association with specific treatment-related adverse events from EV. So in univariate analysis, we found diabetes, prior neuropathy, higher hemoglobin and albumin at the start of EV were associated with neuropathy significantly, lower white blood cell count and neutrophil lymphocyte ratio, and GFR greater than 30 were associated with skin toxicity. And TERT alteration and lower absolute lymphocyte count were associated with cytopenias. Male sex, liver metastases, and KDM6A alteration were associated with anorexia and weight loss. And higher BMI, diabetes, lower neutrophil lymphocyte ratio, and male sex were associated with hyperglycemia. Now, we found a couple of other random associations, but again, these were univariate analyses, so you can have a lot of confounding factors. So what we did for multivariate analyses to really isolate these somatic alterations and see if there was a true association with EV treatment-related adverse events is we had several MVA models that adjusted for pertinent clinical variables. So those variables, so for example, for the neuropathy clinical model, obviously we counted for baseline diabetes, we counted for baseline prior neuropathy, we accounted for BMI, we accounted for prior platinum chemotherapy, and then anything else that was significant on univariate analyses. And then making sure not to have too many factors in the model, obviously to not dilute the effect. So each multivariate model was about 5 or 6 variables that were pertinent. So interestingly, we didn't find too much on multivariate analysis. So we found that MLL2 genomic alteration was associated with cytopenias, and KDM6A alteration was associated with anorexia and weight loss. And again, these multivariate analyses were just looking at each of those 16 alteration groups and the association with the development of those specific toxicities we're looking at. So neuropathy, cytopenias, weight loss, hyperglycemia, ocular toxicities, et cetera, et cetera. And those were the only 2 significant things that we found. So what that really tells us is that, you know, somatic alterations may not play a great role in the underpinnings of EV-related toxicity. Now, the next iteration of our study is going to be to do those multivariate analysis models using clinical variables. Something important to really take away from this is that in trying to develop predictive biomarkers for any treatment-related toxicity, you're not going to find one gold mine, you know, that's going to hit the jackpot and one variable. So it's likely going to be, you know, a conglomeration of different variables, and that's why we're trying to, you know, isolate which different variables could and could not be related to treatment-related toxicity. Obviously, the limitations of these analyses are that it's retrospective, and, you know, the attributions of treatment-related adverse events were decided by investigator at each site. So there is that, but this would be interesting to examine prospectively as well. So the takeaway from our study was that it does not appear that somatic genomic alterations appear to be associated with predicting EV treatment-related adverse events, but this warrants further investigation of host and tumor-related factors, other underlying EV toxicity. I think the biggest thing would be looking at the clinical variables as we will be doing in multivariate analyses, and then using a different data set, working with companies to examine germline alterations in patients and in a prospective data set to look at the specific toxicity associations with certain germline SNPs, as we see with taxane-related neuropathy and breast cancer.